Good afternoon, everyone, and thank you for joining us today. My name is Cameron DeYoung, and I'm the Digital Marketing Manager at EMDs, and I'll be your moderator for today's presentation. In today's Practice Partner Lunch and Learn, we're going to discuss regulatory reporting. Before I hand the presentation over to Susie to get started, there are some housekeeping items to quickly go over. Today's session is being recorded and will be made available to participants after the event. You'll receive an email with a link to the presentation slides as well as instructions on how to access the recording. All attendee lines are in listen-only mode. If you have a question during the presentation, you can use the Q&A and chat tools to submit them to the team. We'll handle all questions at the end of the presentation, time permitting. If we're unable to get to your questions during the live session, we'll make sure to follow up with you directly after the webinar. On your screen, you should be able to see the slides for today's presentation. To view full screen mode of the presentation, please click the arrow icon in the top right-hand corner of the presentation screen, and that will maximize your view of the presentation. That's it from the housekeeping side of things. I'll hand it over to Susie to kick things off with today's presentation. Thank you, Susie.
Thanks, Cameron. Hi, everybody. Thanks for joining. All right, let's go ahead and get started. I've got quite a bit of information, as always. I just want to take the short time to plug our user conference coming up in June 20th through the 22nd. It's going to be in Austin this year versus Dallas, where it's been the last couple of years. We have a lot of practice partner sessions coming up, industry, and all other kind of things, as well as networking. And it's in Austin. You got to come and have fun. All right. So today's agenda, we're going to talk a little bit about the 2015 certification, your eligibility for reporting MIPS in 2019, and pick your pace in 2019. A little bit of conversation about your quality measures and improvement activities, the cost category, and then our promoting interoperability MIPS 2019, and then talk about Medicaid as well, because there's been some changes in the requirements for 2019 from what we had all prepared for prior. So for 2015, the certification, beginning the EHR period in this year, you have to report on the 2015 certification for the self-selected 90-day EHR reporting period. But you don't have to, keep in mind, be already implemented by January 1, obviously, because here we are in March for 2019. So once we go out with the GA for this version 11.2 that is on the horizon to be released shortly, this is the version you'll want to be up on to be able to do your 90-day reporting information for your interoperability, and it's going to be the 2015 certification. Also with your UpDocs patient portal, this is the certified patient portal that will work with Practice Partner, and then you would combine that. So you'll also want to make sure that you're getting up on the patient portal and the UpDocs in order prior to you're ready to report on that 90-day period or however soon you want to get up on that. And this way, then you're going to be on that as well. This is actually GA for CEHRT and Oracle databases, and SQL is right behind that coming soon. So this is something you can reach out to your account manager to talk about getting your UpDocs installed moving forward. And then and as well as your quality reporting, I have FigMD 2015 certification. This is who we partner up with. Obviously, there's other vendors out there you may be using. Just make sure that moving forward, they've got to be reporting for the full year for CQM data, and you want to make sure that they're 2015 certified when you go out there, so that when you go to a test, you have that number to marry up with your EHR and the UpDocs portal. So it combines to make that cert number, allowing you to attest. So for this year, you can see that they've added physical occupational therapists, speech language pathologists, audiologists, nurse, midwife, clinical psychologists, and dietitians to be included in the MIPS eligible clinicians to be able to report. However, you all want to make sure they're no different than any other provider, physician up to this point. Are they eligible to be able to report? They may or may not, depending on how it is that you're reporting. So you want to check that out on the QPP website if this is something that you're going to do to make sure that they can. And it all boils down to how they've been billing and the amount of claims and so forth that's going out on that as far as being able to test for them. Also understand that, physicians defines a physician as a doctor of medicine, DO, podiatrist, optometry, as well as chiropractic in a certain realm of things. So again, on your chiropractors, if you're working with them, you want to verify if they qualify or not. So, and I would do it very soon so that you know whether they're going to have to report or not, so they don't take a hit on this, or what is going to be the process of going on to it. So that's just something you want to take into consideration for this year, and if they're eligible to report, to move forward on that. We also have a pick your pace in 2019, and so it's a little tighter than it has been in the past. And this is just kind of a graph of information of scoring on here that you can see. My next slide, I broke it down a little bit further so that you can kind of see basically if you have less than 30 points, you're looking at a -7% penalty in 2021. So that's where you want to check the eligibility, and then you want to make sure that if you are going to be report, that you can at least come up into this 30 to 74 point realm of things so that you can at least avoid that penalty, or possibly push it up to be able to get a little higher, and then maybe even look at an incentive of up to 5%. And then the higher score, 75 to 100, you're looking at a positive payment adjustment in 2021 with possible exceptional performance bonus information that goes on to that. So that's what you're really looking on Pick Your Pace this year. So it has changed a little bit from last year, got a little tighter on that. So again, if you haven't started already, right now is a good time to look at providers and to see if you do qualify, and if you do, what steps you're going to go ahead and take. So under the quality performance category, it's also changed to 45% of the total score, where it was last year was 50%. You still must report on 6 measures, at least 6 measures, and you have 1 outcome or a high priority measure. Alternative, a specialty sub measure set may be used. Report 60% of applicable visits from the full calendar year, meaning that basically January 1 of this year, 2019, it started to be able to pull through. It's also important to review those 2019 measures sets, as there are new measures and many measures have been removed. So if there's some measures that you have been reporting on in the past, you want to make sure that you're aware of that so that you're not thinking that you're going to go down that path and they've been removed on that. I do know from working with FigMD that on your dashboard, there's a place to go in and look at those measures and how they've changed. So I'm speaking at FigMD. If you're using another vendor, you may want to check on that so that you can update and change this. The other thing that I would also suggest is, again, we're working into almost 3 years now of working with registries and recording this data. And there's some measures on there that you may have been reporting for a while, like possibly immunizations, and you never give immunizations. That might be something that you might think about. Maybe I don't want to really report on that anymore. I want to move something more specialized as to what you really do to get your score up higher on that, just to, because this whole program is about really what you do as a specialty and how you can report high on that, not just because you have something to select on that, but you want to make sure. And now's the time to look at those, of what you're reporting on and what you're going to select, and then be very diligent about moving ahead on that and understanding what is required. Because if things have changed, you may have a workflow that you've been using under the assumption that that is working, and then if they've changed it and you don't check on that, that is going to affect that overall score and the quality measures on that. And ultimately, it kind of comes down to you as what your reporting is, to be on top of that, to be able to understand that and get things changed. You also have in this year, individual clinicians in a small office and small practices or a virtual group can submit quality measures through Medicare Part B claims. So if this is something you've been doing in your small practice and considered under that, you want to make sure that you are submitting claims data on there and to continue on out with that to be able to go ahead and report on that and make sure that when your EOBs are coming back, you can see that they are giving you points towards that reporting information that pulls onto it. Registered groups and virtual groups with 25 or more clinicians can submit through the CMS web interface. And then again, what most of us are doing right now are authorized third-party vendors that we can perform direct submission, which would be through the QCDRs or the qualified registries to be able to submit data. And so that's where A lot of us are at this point and submitting through that vendor to be able to go ahead and submit the data. And I just want to just kind of say it again, is even to this year, I've had questions come back where we've had people still trying to export data out of the EHR on those quality reporting tool. And there's not an electronic file. We have not updated that. There's no electronic file that you'll be able to export out of there and submit up to the QPP website. We quit updating that. And so I just want to make sure that if that is kind of new to you, that you understand that. And at this point, you get out there and decide how it is you're going to report your quality measures. Again, we party up with FigMD, but there's a lot of different options out there to use, and you may want to look at that. I would also say if you're going to use something that you have to hand enter data into it, like a mixed wizard type of format, you want to start doing that now and start getting that information entered in, because you don't want to wait down to the very last minute and try to get all that information in for at the end of the year. So just kind of keep an idea of what you're going to do on that and start moving towards to be able to report on those CQMs. The improvement activities, this is makes up 15%, and basically it rewards the eligible clinicians for participating in predetermined activities aimed at improving quality care. Clinician groups should choose and participate in activities most relevant to their practice and patient population. So those activities are all listed on the QPP website, and you may want to look at that. It may be something that you've already been reporting on. You're going to continue doing on that because it's improvement. Maybe we're working on getting things improved on our standards of what we're doing on that. So that information comes through. To earn full credit on this category, you must submit one of the following activities. Each activity must be performed for 90 continuous days or more during 2019. So you have 2 high-weighted activities. And again, on the QPP website, it documents what are high or what are medium activities, or 4 medium-weighted activities. So it'll tell you right on that side, if you haven't looked at it, what the weighted activities are and how they are. Also keep in mind, is under the special status, if you're individual, group, or virtual group, small practice, like we're saying here, non-patient facing rule, or HPSA, you can go ahead and you still get the same status that we had last year. You can receive double points for each high or medium group to be able to use on that. So just keep that in mind if you're considered anything under the special status. There are also 6 new improvement activities available for attestation in 2019, and I have them listed here. If you want more information on that, you just need to go to the QPP website and kind of look them up by the name information on there. But they've added some things that may be pertinent to your use or not, depending on what your specialty is, but you'll want to look at those if it's something that you need to go in and change, or if you're an optometrist or ophthalmologist, this one is probably a pretty good one to go in and use on it because it's comprehensive eye exams that would be due, and it wasn't there before. One activity was retired this year, and it's the participation in population health research. So if this is something that you were using in the past, you may want to, you're going to want to look, it's been retired, so you'll want to change what it is that you're going to report on in 2019. The one thing I can stress about these improvement activities, again, is that they're basically, when you go to test, you select what it is that you're testing to, and you're saying that you're doing this for 90 days. I would recommend, again, what am I doing for 90 days, and how can I prove this in case they come back and audit? Because it would be it's a good target for an audit for them to come back and audit you. Because you might say you're doing it, but then if you can't prove it, then if you've received a bonus, they're probably going to knock you down a little bit on that. So make sure that you can support those improvement activities, whatever it is that you choose, and have it documented just like you do everything else in case you get audited on those. Same as, again, with improvement activities, patient-centered medical home. You're pretty much excluded from that if that is your classification of doing that as far as improvement activities go. You don't have to report to them because more or less to meet this status, you're already getting a lot of those done and out of the way to be able to keep that status going. So the cost is making up 15%. It's in the second performance year that they've been weighted that against your final score. And the one thing to keep in mind, that there's not much you can do on your end of it, clean claims, make sure your coding's good, that kind of information. But really what they're looking at that cost is the expenditure, the spending per Medicare beneficiary. And that is automatically being captured by your claims going through. So you're getting points on that information as claims go onto it, but it's not anything that on the EHR side of things or anything that you're having to capture on that end of it, they're tracking on their end. All right, when we talk about promoting interoperability, which is formerly the ACI information that comes on, that's what really this year is all about and probably moving forward. So they've made a lot of changes on that. And the idea behind that is to be able to start having more patient engagement, as well as sending data to other EHRs. Receiving data is big on this year, and the changes coming into it through the use of direct messaging, and to be able to import information that comes on. So they've actually done some changes on there. Must report on all required measures across 4 objectives, which we'll look at here in a minute. Those have changed dramatically. There's been a big change in this. And then the performance measure is gonna be over at least 90 consecutive days, same as what we did last year. Information that you've got to be able, when you attest, it has to be a consecutive 90 days. You can attest for more days, information on that, but it's got to be 90. And if a clinician fails to report on the required measure or claim exclusion, if applicable, the clinician will not receive a score for the PI performance category. So more or less, it's just like we did last year. If we couldn't, let's say you didn't have direct messaging set up and you didn't send out a summary of care and you didn't have that, then obviously you couldn't, that was a required option, and if you didn't meet that, then you couldn't report for this category. It doesn't keep you from reporting for MIPS, but it makes you, it takes that 25% of that score away from you. So that's what you're looking at, information that goes on. And then again, you must be on the 2015 certification in order to receive the category credit. So this is again where we'll be rolling this out, and you'll want to be able to get up and running on the 11-2 in enough time, so even if you attest towards the last quarter of the year, that you have time to be able to get up on it, using it, because of the big changes coming in with the enterprise and all that information going on to it. So you have the capability to even focus on this other stuff. So these are the new measures, and you can see that it's been a drastic change from what we had in there. We have, basically they took the e-prescribing, so we still have to e-prescribe, but now there's a bonus query, a prescription drug monitoring program, which is 5 bonus points, and we'll talk about that in a little bit, as well as verify opiate treatment agreement, as well as 5 point bonuses. So you have a little extra on there. There's exclusions on that. Not everybody prescribes in this area here as well, and it's not going to be required for this year, but it could be a bonus point. So I have it broken down in your slides here a little bit further. Also, the health exchange. This is huge. As I start breaking down into it, the first one is support electronic referral loop by sending health information, and that's 20 points. And then the other part of that is support electronic referral loops by receiving incorporating health information. And a lot of it focuses on data coming back into us versus data going out, like we've been doing for quite some time on the summary of care information that pulls in. So it's going to be more focusing on the data coming in and incorporating it into the EHR, as well as doing clinical reconciliation, overall information that comes back into the system. So that's a little bit change, information that pulls on to be able to incorporate that. And the provider patient exchange, so provider to patient exchange, they changed these names, and what used to be having electronic access to the health information. So that's 40 points. You can see it's a big one, and as I said earlier, is for the 2015 certification that will require that you go on with patient portal and to be able to give access to health information that comes on. But there's a lot of points included on that for having that ability to be able to do that. And then we have the public health clinical data exchange, which basically it's saying that you have to do 2 of these, but there's a lot of exclusions. So it's not a lot of different than we've been doing since 2011. I mean, they were telling us we had to do syndromic surveillance, but then, you know, the state wasn't ready to do it. So you still have those types of exclusions coming onto it, as well as then if it's something you're doing, you just have to prove that you've got some activation information going on, and that's worth 10-point information onto that. So this is really with the measures that come on. So you can see that a lot of things have changed, and the world as we've known it up till now is going to change a little bit as well. So they've changed some different names, replacing base, performance, and bonus measures with one set of objectives, which you just saw in there, information that comes back. The clinicians are required to report the same measures with the 6 measures, 3 objectives, just kind of like the information we went through. So what we just looked at in this previous screen, these are required. Anything with an asterisk on these mean that there's an exclusion, so it may exclude you if there's just certain things that you don't do, and to be able to exclude on those, and be able to, when you go to a test, to exclude on them. Also, you're going to have performances based on the numerator denominator of each measure, except for the measures associated with public health and clinical data exchange, which is a yes, information that goes on. But then, again, if I'm a yes and I'm getting onto it, I need to make sure that I can prove that I'm in active relationship of getting that set up onto that, or I would exclude from it. And then protect patient health information objectives, which that is still there. Your security risk assessment hasn't gone anywhere. You still have to do it. It's just not on that main screen like the main requirements like they've showed us before. So it's required on there because, again, it's more HIPAA than anything, but you still have to say yes or no on those submissions. So it hasn't disappeared. It's just not showing up with the main objectives. And then points will be outweighted to other measures when exclusions are applicable. So again, there's a lot of exclusion information to be able to on that. So let's talk about the new optional bonuses for opioid treatment, agreement, and query for the PDMP. So basically, those have been added for this year. And then we also have removed the government removed the 2015 edition CERT bonus. We had that up until last year, and if you were on the 2015 certification, you could have received a bonus information that pulls on. So that's no longer on the table because everybody's got to be on 2015 this year. There's going to be new hardship exceptions for clinicians for small practices information. So there again, if it's a hardship that you're going to need to maybe look at, that's something that also right now is a time to think about it, information to go on and understand those changes. Exclusions added for the e-prescribing and health information measures, which we've kind of gone through to show that those changes. So to begin with, the ACI report that we have that we had implemented into it, and we had all of the requirements that were needed and got certified, then CMS comes back and changes this. So I just want to let you know that we will be updating this report to reflect the changes made by CMS. Because what we have on there now, there's certain information like the health exchange. There's going to need to be changes in there, and that workflow that comes into it because there's a lot of kind of switching away more of the information coming into us, and then the ability for the ACI prescribing, and then to be able to options to be able to report those extra bonuses information that comes on. So I don't have an estimated date on that yet, but those will be updated and changed, just so that you know that. So you don't go out there and try to run this and say, I don't have that information. Know that we're working to get that updated for you. So here's removal and objectives and measures. So these things are no longer required. We weren't required to do secure messaging, but we got extra points for that. The view, download, or transmit is really not there anymore. It's more kind of combined in giving access to that. And then patient-generated health data, not gone. Request, accept, summary of care is not there. Clinical information reconciliation, the measure is not there. As I kind of go through this, though, I still would recommend that when you're importing data that you are getting this done, not so much as you're going to report on that specific measure, but you'll see when those health exchange information is required that we do that full clinical reconciliation come back in. So the workflow would be something to be able to continue doing that. And then our patient-specific education is no longer being tracked as well. So those are no longer there. So again, if you were to run that ACI report and add these extra messages or extra measures on that and that information, at this point, what you're doing would be more on, you're not going to have to test to it, but if it's something that you're tracking and being able to improve on, you still have the ability to do that, but just so that you know that you won't be attesting on it. Okay, so then there's been some different name changes on this. I won't have to go through each one of those, but there again, they changed what it is that we knew up until now, and so these are just changes in there for 2019. And again, right down here, provider patients' electronic access to their health information was formerly provide patient access measure. And then the patient-specific education measure is currently associated with the objective will be removed in 2019. So that's just information knowing that some of these things have been changed. Some of them we've been doing a long time, and so if you're still doing it, it's not like it's going to hurt anything. It's just knowing that you won't have to attest on those. All right, so the e-prescribing is generate, transmit, permissible discharge prescription electronic, and then e-prescribing for at least one hospital discharge, medication orders, or permissible prescriptions for new and changed prescriptions are queried for a drug formulary and transmitted electronically using certified EHR technology. So as we all know up to this point, we will be on 11.2, and then the enterprise will take place will take the place of the formulary that we have now that we download. You no longer have to download this formulary information that comes in, and the enterprise will make a change on that, but you'll have the capability to be able to do that once you move into it and query the formulary as it goes on, because it's included in the whole enterprise process. We have the new measures coming into this is to prescribe objective, verify opioid treatment agreement measure and query of the PDNP measure. So really where this is coming from is that the Department of Health is working really hard to combat the opiate crisis information that comes into it. So that's where this measure is coming in, and to be able to start gathering data and to help manage that better. And then it's aimed at reducing the risk of opiate use disorders, overdoses, appropriate prescribing practices, and drug diversion. So that's kind of why that came on new measures, being able to choose from it. And the scoring on the query right now, like I said, it's worth 5 bonus points. It's optional in the calendar year of 2019. So it's not, you won't have to report on it. If you do, then it would be 5 bonus points extra, but it will become mandatory in 2020. So that's what I'm saying, is getting our ACI reports up there so you can be able to, if it's something that you're tracking, to be able to utilize that. And then the Verify Opiate Treatment Agreement measure is optional also in 2019, and 2020, and it's going to be worth bonus points coming on to that. So there's just the new changes on that to be allowed. And again, because they changed so late in this last year, they are giving us a little bit of time so that we can get things set up and be able to refine that on that information as well. So you will see that information coming in, so just know that it's there, and then the change is coming. All right, so this is, again, this is just your bonus for at least one scheduled opiate electronic prescribed using certification and so forth going on to it. So I just kind of put that in there so that you'd have it. Same with this next one, is to verified opiate treatment, and then they're just telling you what it is that they're looking for and the requirement information behind it. The numerator on this is going to be the prescriptions in the denominator generated, queried by the drug formulary and transmitted electronic using CEHRT. And then the denominator is going to be the number of prescriptions written for drugs requiring a prescription in order to dispense other than controlled substances during the period, or number of prescriptions written for drugs requiring the prescription in order to be dispensed during the performance period. So you've already seen on the ACI report, we have updated the e-prescribing to accommodate enterprise coming out on that. So there's this information, and you can see now, even in this year when you tested, you were able to have reports that you were able to look at your prescriptions that were non-controlled, and then if you are sending controlled medications electronically, then the other combined on that. So that's a lot of the reason behind that, to be able to use those for e-prescribing and the reports. But again, like I said, we'll be getting those updated and out to you as soon as we can. This is just more information as permissible drugs meeting the certain criteria. So it's not anything new that we've had on there. There again, controlled substances can be included in the permissible drugs, but you have the ability to break those down now in your PMSI. So you may be in an office where scheduled medications are not written that often, that kind of thing that goes on to it, but understand that this information then will be incorporated with that enterprise once we go live with 11.2. There's an exclusion in here, and that exclusion is for anyone who writes less than 100 permissible prescriptions during the performance period. So you have that ability to exclude from that. That hasn't changed. Health information exchange. So this is a big one that comes in. So up until now, we were used to sending out the summary of care via direct messaging, send it out to the system, and then this last year, we introduced that the system had to be able to recognize that it was sent out via the clearinghouse and then being accepted on the other end of information that's coming back in. So that hasn't changed, and Medicaid's still going to require it this year as far as the outgoing information that comes in. But now with this new one, it's really telling us that for at least one electronic summary of care record received for patient encounters. That means that it's coming back into us, that the eligible clinician was receiving party of a transition of care or referral for the patient encounters during the performance period. And it goes on to tell us that it would be for a patient who's never been encountered by the patient, and the MIPS eligible clinician conducts clinical information reconciliation for medication allergy, and current problem list. So really what they're saying on that is when we import data into our system, there's an ability to go in and do a clinical reconciliation, and that's where that's going to drive from on that information that pulls on. So you can see where it's not so much outgoing as it was before. It's more incoming information to us. I think probably that next step is to be able to get us to start bringing information into the system versus just output that we had before. And we will have workflows set up for this information to get out to you as well for the system going into it. So there is exclusions on this. You basically, if you are unable to implement the measure for the measure's performance period in 2019, would exclude from this measure, or any MIPS eligible clinician who receives fewer than 100 transitions of care or referrals, or as few as 100 encounters with patients never before encountered during the measurement period. So again, with these things, if it's something that you can exclude yourself from, then again, you would want to make sure that if you're going to exclude, that you could prove, if they came back and asked you, how do I prove that I had less than 100 information that comes on? So just as an idea is, just because there's an exclusion there, you want to make sure that you can stand behind that exclusion in case you were ever to get audited. This is, again, the numerator is going to be the number of electronic summary of care records in the denominator for which the clinical reconciliation is completed using the CEHRT for the following 3 clinical information sets. So this is our medication, allergy, and current problem list. So again, we would have a clinical encounter that comes in. It would be marked as relevant for clinical reconciliation, and then those 3 reconciliations would need to get performed in order to be able to get update on that. So we have that information into it, but I think that the ACI report will look a little different than what we have, because currently that ACI report documents it outgoing, not what's really coming back in. And then the denominator is the number of electronic summary of care records received using CEHRT for the patient encounters during the performance period, for which the MIPS eligible clinician was receiving the party of transition of care for referral, and for patient encounters during the performance period for which the MIPS eligible clinician has never before encountered the patient. So then it's probably going to look at your status of maybe new patient information like that. It's also going to have some criteria on that as well. All right, so the next one is going to be receiving and incorporating health information. And to me, when I look at this, it's almost kind of the same thing, information that comes in. It's going to have to be a transition of care or referral received or patient encounter for which the MIPS eligible clinician has never encountered the patient, and then that information comes back into it to be able to receive that and incorporate the data into your EHR. So at this point would be an import medical summary to be able to bring that information in and then do the reconciliation. So in reality, they're both kind of the same information, but it would just be bringing that information into your system. And it doesn't say that you have to do every one of them, but it is going to be able, you're going to have to be able to change on the HIE. So just kind of start thinking about that, and we will get the updates out to you as soon as you can. Information. If you're already doing it and you're incorporating data on that, you're ahead of the game. All right, the next one we're going to talk about is the provide to patient exchange. And this is for at least one unique patient seen by the MIPS eligible clinician or the patient or the patient authorized representative is provided timely access to view online, download, and transmit his or her health information, and the MIPS eligible clinician ensures the patient's health information is available to the patient or authorized representative to access using any application of their choice that is configured to meet the technical specifications of the Application Programming Interface API in the MIPS eligible clinician certified EHR. So with that, what that is saying is, as far as on our end, we have implemented the UpDocs patient portal, and with that application of API, that's what's been set up to design to work with Practice Partner. If you were to go with something else, you'd want to make sure that if you're using it, it's probably not going to interface so much with Practice Partner, but you'd want to make sure that you can match up and marry those numbers to be able to use on that. So that's really what it's saying there, information that comes through. So when it looks at this information here, your denominator is going to be the patients. Basically, it's still going to look at those patients coming in, the clinical encounters created of the patients being seen is going to be the denominator, and then that number of patients who've been given access to the portal. So let me explain again, is that you'll want to be up on UpDocs, and even if you're going to test the last quarter of the year, I would recommend that you get up on UpDocs as soon as you feel like you can go ahead and get that done. That way it's going to give you time to go ahead and implement it. When you migrate from WebView to UpDocs, it's going to look at your patients, and it's going to, as long as they have a valid email and they are active to WebView, those patients then will migrate into the system once you do the migration. And that information, then those people would already have access. They would receive an email saying, you know, we just updated this portal and so forth. However, if you don't have active emails, those patients are really they're not going to actually have access when they go to UpDocs, because there's no output there to be able to have that information. So you may be at WebView, everybody has access to WebView and everything else, but your practice has not been to collect valid emails. So that may be something that you're looking at, again, some specific stuff before you start migrating over to that, so that you know that once you get migrated into that, everybody's going to have access that needs to it, or if they don't, then you'll want to make sure that you're getting on and giving them access back to UpDocs, information that pulls onto that. So just kind of, again, it's food for thought on there as far as moving on to it, but you will want to get, in order to meet these measures, you'd have to be up to UpDocs information on that. This is just API programming interface information. I just put a definition of terms just so that you have it there. I'm not going to go through each one of them, provide access. I will say down the timely access, again, the way UpDocs works, the timely access comes into, they have access to it, and then once a progress note or labs are signed, or basically any note that you have that the provider is set up to sign, information that pulls through, when those signatures are signed, the system is going to sweep and send clinical encounters ongoing as it goes out. So that covers that 4-day information that pulls onto it. So that's where that kind of ties up into that to be able to get done overall. But you will just kind of want to kind of read that information. But the UpDocs is set up to be able to qualify for that measure. So you've got your public health clinical data exchange information, and these are the clinical data information that they say on there. And it says report to 2 different public health agencies or clinical data registries for any of the following: immunization, electronic case, public health, clinical data registry, or syndromic surveillance. And this really hasn't changed so much from what we've known in the past, that basically we've always had to kind of do something on that with meaningful use, but not all of us gave immunization, so we didn't have an immunization interface. Not all of us even do things that would be reported up to a public health or syndromic. So what it's really they're telling us is that you're required to submit at least 2 of the 5 measures to public health and clinical exchange, objective for 10 points. If the clinician qualifies for an exclusion and can only report 1 measure, then the point value for the measure will be reweighted to 10 points. So it's not like they're going to ding you on that, because again, a lot of us are really just reporting up to our data registry for our sending data up to that CQM information that comes on, but we may not be doing immunization or anything else on that. So you're not really required to have 2. But you just want to make sure that if you are, such as immunizations, and you can report on that, then this is the discussion about active engagement. So I'm not going to go through all that. We've had to kind of deal with it for the last few years on that, but if you are in active engagement, it's important that when you report yes, even if it's not set up on there, that you could prove your active engagement information that comes on. So everybody's on the immunization, not everybody, but if you're given shots and immunizations out there, you may already be up on the immunization registry. So that's just information that I gave to you on that. And then what I really did under the rest of these is I gave exclusion information on that because you may, but a lot of it boils right back down to the state, and if the state has the ability to be able to collect on it. So at this point, you know, if you're submitting syndromic surveillance data, you probably already know it, and you already got the interface going on to it, so you'd be able to go ahead and attest to that. If not, then you could go ahead and select one of those exclusions. Security risk analysis, as I said, that doesn't go away. Even though it's not documented on our little list of things to do, it's still required. Same requirements coming onto it, so you want to make sure that you're getting that done and conducting that review and being able to say yes to that and be able to support it. Also, when you go to submit, you're going to have to say yes to the blocking information attestation, the ONC direct review attestation, and then yes to the security risk analysis. You probably would have done it already this year. It was required this year, and it'll be required next year. Medicaid. So again, with the Medicaid providers, you'll still go ahead and report promoting interoperability program. It's no longer meaningful use stage 2 or meaningful use stage 3. It is called promoting the interoperability program and attest directly to their state, so you still would be using their website information that comes on. For 2019, the EHR reporting period for new and returning participants to CMS is a minimum of a continuous 90-day information that pulls onto it. Here are the new, I don't want to say new, but these are the changed information that comes on, which you'll be required to report to for this year. Some of it is kind of the same information on here. You still have to do your security risk analysis. You'll do your e-prescribing. You also have to report to your clinical decision support, and then your computerized provider order entry. You'll also have to prove electronic access to health information, coordination of care through patient engagement. Both of these two measures here require the Docs Patient Portal. The health information exchange for this, it would be the use of sending out a summary of care via direct messaging and to be able to use this. And then on that stage 3 report that we have in the system, information that comes on. And then you also have your data registry reporting as well to attest to. This is a link to these measures here that if you don't have them, you can link up to them and go back and check them out to make sure you have everything you need on there. This hasn't changed, still the same thing, security risk analysis information, you have to attest yes to it, make sure you have it on file that you could prove that it was done. Information that pulls through. E-prescribing, again, is to be able to send e-prescribing information, and it's going to track on your report. Clinical decision support, it's not changed really from what it has been from modified stage 2 information that comes on, but you're going to have to implement clinical decision support information focused on improving performance information that comes onto it. And this measure, again, is a yes, but then you want to make sure that you can prove that of what it is that you're choosing on that information that comes down, and implement functionality for the drug-drug and drug interaction checks for the entire EHR reporting period. You want to, this will again come in your enterprise information that's pulled in, you'll have that. And there again, you can exclude from that measure if you're writing less than 100 medication orders for the EHR period. So this is just a list of your CDS information on that. I just kind of made a list of it. I know that, again, it's something that's been going on for a while, so most of you probably already have that down and what it is that you're doing and utilizing in the system. Practice Partner has a lot of those options to be able to use. If you have questions about what that is, I have a Lunch and Learn out there that I can send you the slide deck on there that I broke those down for CDS for Medicaid. Computerized provider entry, again, this is the same configuration as I've got my labs, I got my radiology, and I've got my medications. The medications are automatically going to pull. Again, and then my laboratory and my radiology is tied into my order information that's set up, so you'll want to make sure that you can attest to those. And then a patient access health information. As I said, this is the ability to have the patient portal with timely access to their health information and patient-specific education. Now, with the patient portal and UpDocs, to send that education over into that clinical summary, you would want to make sure that you're using the patient education module in Practice Partner, launching it, and the patient education comes up, because once that's associated to the note, when that clinical encounter goes out to the patient, it's going to document what that education was, information that pulls onto it. WebView did the same thing, the information as well, so just not much difference on that. And there's your UpDocs again. Same with the coordination and care through patient engagement. With UpDocs, you also have the ability to have family members associate with patients. It's more up to the patient to be able to add that authorized person to have access to their data, but you have that ability to be able to do that. So you'll have that option once you go to UpDocs. Health information exchange. So this is again to provide a summary of care when transitioning to a referring provider. Care receives or retrieves a summary of care record upon the receipt of transition or referral information encounter to a new patient. So this is kind of the same in a way, I mean, as far as sending out a direct messaging, but again, that they're looking at being able to bring data back into your system and then do a reconciliation of that clinical reconciliation, bringing the data back in and into your system to be able to show that interoperability between one provider and the other. And there's your public health registry and clinical registry reporting information that comes onto it. So you had this last year information that comes on, it's a yes or no. And there again, if you got your immunization set up, information, and then a clinical data registry as well, you'd have that option to be able to report on that. You do have a stage 3 report, and those objectives are all listed right in here to be able to document on those for the 2019. And the one thing I might add, because this last year you wouldn't have had to use the stage 3 for your health information exchange, this report requires that when you send out a direct messaging, if you're going to send a summary of care, that you send it from a direct message to from a direct email to a direct email, so that the clearinghouse, when that information goes out, that direct email went out, that it's going to go ahead and update your system to be able to document that. The modified stage 2 report, if you chose to the 2015, that requirement wasn't so stringent on there, whereas this one is on that. So just make sure that when you're recording that you're getting, that basically you've got to use direct messaging to be able to make that measure work to go from and to. All right, so we've got some upcoming lunch and learn sessions, and the next one's going to be more enterprise information. It's probably on April 3rd, some more information coming, and I'm hoping to get some help from Bob and Dave on that, so we can kind of work more on the, what we want to do is really make sure that we give you guys the ability to work on the installation and upgrade of the new 11.2 and all that process that goes through it, so that once we go live, then you guys can go ahead and have what you need to be able to get out there and get that done on that. So those are going to be the next 2 sessions. So a lot of it's going to be really focused on the enterprise and then the installation of 11.2 information that comes on. All right, looks like I do have a little bit of time for questions on that. And Cameron, if we want to go through them or whatever you want to do on that.
Sure, thank you, Susie. Great presentation, and we do have some questions that we can go over, and what we don't get to today, we'll certainly email responses to. I see a couple that were answered already as I'm scrolling. I just want to make sure I get to them. And again, if we don't get to it, we'll certainly get to those afterwards. So the first question I see here is, are we going to have something in an e-prescribing to say it's from a hospital discharge patient to meet this measure?
I don't know that yet. They're still in the process of working that, but I'll go ahead and have it on my list because there's got to be some way to be able to track that as far as your numerator and denominator. Okay.
And another question is is public health back to a requirement or just a bonus like the last 2 years?
It's not a bonus. You've got to select two of them. And so in other words, you've got to select two, but if you cannot, so let's say you have public health and you are in active engagement, then that's when you would select, and then you would be in active engagement of it. It's not going to be a bonus anymore. If you cannot select two, you could only select one, then you would go ahead and get the 10 points on that, but you'll have to exclude from the other. Make sense?
Okay. Awesome. Thank you for that. Another question is, what exact transactions do clinicians have to submit with the claim to report 2019 qualifications for MIPS?
Submit claims? Is that what qualifications for claims? Is that what, say that to me again, Cameron, I'm sorry.
No, it's what exact transactions does a clinician need to submit with the claim to report 2019 qualifications?
So you would have to report all of those, their level 3 CPT codes basically. And if you go to like the QPP website and you bring up the measure you want to it, they have the specifications on there. And it will tell you what codes that you would bill with your claims. And so, for example, if it was performed that day, if it wasn't performed that day, it met the measure, that kind of stuff. And so it documents all of the different specific codes that you would bill to it. So more or less what you'd want to do is for whatever, when you're sending those claims, and it would be Medicare claims at this point. It's not others unless you're doing, sometimes other carriers require those, but you'd have to get those codes from there. So CPT codes you'd set up in your system, depending on your clearinghouse, would depend on whether you had a penny associated to them or just a zero balance. And then you'd go ahead and submit those out. And then when you get your EOB back, it's going to tell you, it'll go ahead and list those codes on your EOB, and then it has the adjustment code on there, the reason code on there that it is for reporting.
Okay. Awesome. Thank you, Susie. Another question is, who is required to do the reconciliations? Does it have to be the provider?
As the report stands right now, it has to be the provider logged in. But that is only, but I'll put it this way, that would be to show numerators on the ACI report. But does that mean that, once they get those once they get those updated, that could change? I mean, really at this point, and I don't have a specific as to how they're going to go ahead and report on it, but if you've got to come back and do a reconciliation, they've got to be able to collect that data somehow. So I guess that's kind of where it would stand right now. As we stand right now, to get points on the ACI, it would have to be the provider, but once that gets updated, then that could change.
Perfect, okay. And when will there be another webinar on the MIPS to iterate all of these requirements, including how to implement them completely?
Once I get the information, I'll get it out to you. I'm not going to hold off. I'll get it as fast as I can. Once I can get it reported to you, then I will. Great.
And let's see, I'll go with one more, and then we'll get the rest answered via email. Sites that have will sites that have web view need to use UpDocs for the portal for 2019? And I'm trying to, read this. And let's stick with that part of the question. Will sites that have WebView need to use UpDocs for the portal in 2019?
Yes. You will need to implement UpDocs for your 2019 reporting. So that's what I'm saying is that this is something that you really need to get on your calendar as to when you want to do it. You do not have to do it at the same time you update to 11.2. And I wouldn't recommend that you did it all at once either, because there's a lot of file changes, that kind of stuff. But you're going to want to have it implemented before October 1st of 2019 because of that 90-day period. So I would think that at this point, if you're CEHRT or your Oracle, it might be something that you get on your docket sooner than later and get that implemented, and then you can get your 11.2 updated a little bit later, so that you're not dealing with all of this change all at one time, kind of, you know, stage information that pulls onto it.
All right, thank you again on that, Susie. And what we're going to do now is the remainder of the questions. We have a lot of questions coming in, which is great, and we'll and some great feedback from some of you as well that we're going to be able to share with everyone when we send out the information from today's webinar. But the remaining questions, what we'll do is we'll put those together in a document, and Susie will have those right after the call to be able to get in touch with you. I do definitely want to thank everyone for being part of this webinar today, and it's always important to be able to share this information with you. And a special thank you to Susie, as always, for being a great host for the webinar. So thank you so much.
Thank you. Thanks, everybody, for joining. Bye.